To have Dr. Wolf and Maren Johnson here with us today. Dr. Wolf attended George Washington University Medical School, after which she completed her residency in general surgery at Boston University, and then a fellowship in laparoscopic surgery at Vanderbilt. She worked in Boston at St. Elizabeth's, where she started their bariatric surgery program before moving to Maine, where she became the director of Weight and Wellness Center until moving to the Netherlands, which sounds like a story in and of itself. She received her MPH from Dartmouth and is currently working towards her Master's of Bioethics at Columbia. She's a strategic consultant for meaningful community engagement, working with the Division of Preventive Medicine. And Maren Johnson is the director of prevention programs for Maine Medical Center's Preventive Medicine Enhancement for Maine, PrevMe, right? And Community Informed Care Initiative, PrevMe's Community Health Worker Program. She received her bachelor's degree in journalism from the University of Wisconsin-Madison, go Badgers, and a master's degree in nutrition from the University of St. Joseph's in Connecticut. With her background in journalism, nutrition, research, healthcare, and project management, Maren brings experience and knowledge for preventive health and education. Maren continues to build programs within PrevMe, including group medical visits, exercises medicine, foodist medicine, Project Echo, and most recently, the Community Health Worker Program. So I will turn it over to Dr. Wolf and Maren Johnson to present.
Hi, everybody. We just are actually really grateful for the opportunity to talk to you, because we're excited about new collaborations that may develop in research. And if you can go to the next slide, that'd be great.
Yeah, sorry, I have my displays mixed up. I'm
okay.
at the office. I'm at the office today, so everything's a little different. So stay with me. I'll try and get this figured out.
No problem. Basically, what we hope to do is talk a little bit about co-production, what it is as it relates to healthcare, how we've applied it in our community initiatives, and what the opportunities might be for co-producing research. So I think you can skip a couple ahead if you want to, if that's possible. And we have no conflicts of interest to disclose. Next slide, please. There, perfect. So I don't know how familiar people are with co-production, but co-production was an idea that came, although I almost hate to say it, from economics. It was a coin that was termed by Victor Fuchs in the late 1960s. But in healthcare, Paul and Maren Batalden at Dartmouth really pioneered the use of co-production in healthcare over the last 10 to 20 years. And I'm happy afterwards to provide references for that, because they've got some great papers. And basically, the principle of co-production is that a product is better if the end user has input into its development. So co-production is really a way of doing things that combines different people's strengths to achieve a positive change. It is making decisions with people instead of for them. And over the last decade or so, what co-production means in terms of healthcare has really become defined. And there is a body of research that has been investigating its effectiveness, particularly in meaningful community engagement. The co-production of health has been shown in a number of studies to improve patient outcomes, to improve patient and provider satisfaction, and to do so with cost effectiveness. Co-production saves money because when patients or communities participate in their healthcare or in public health initiatives, the resulting plan and the resulting project ends up having more compliance, there's reduced hospitalization, and the interventions are tailored to the needs of the people. And that is, why it makes for an efficient healthcare intervention. Next slide, please. So co-producing health or healthcare initiatives, it's hard work. There is a lot to it. And part of what's hard about it is that it's just totally different from the way we do things. In co-production, the emphasis is on the process and not necessarily the outcomes. And that's a little bit different for a lot of, our algorithmic approach to things. So we often say that co-production is both iterative and dynamic, but what does that actually mean? It means that sometimes when you start, you don't really know where you're going to end up. It means that you have to be open to listening to perspectives that are very different from your own. And then you have to regularly assess and put in a system to assess on a regular basis the opportunity to revise your project as you go. Be willing to switch gears. So there's not only some uncertainty involved in co-producing health, but a lot of flexibility. And some of that is good because that means you can be responsive to people. So we do this by including members of the community organizations, community leaders on our planning boards. And then we have regular meetings to discuss what we're doing and if it's working. And that sounds easy, but like actually figuring out what time people meet and how to get a hold of them and et cetera can be like herding cats. In our Ask the Doc sessions, the meetings were facilitated by a community health worker in a town hall format with topics that were picked by the community members. In our Project Echo, we had a balanced advisory board with a hub team, a half from the community. We met regularly to review what we were doing. And that Echo actually was so successful that Sanjeev Arora, who you probably are all familiar with, the founder of Echo, reached out to me and asked if he could present our process to an international co-production meeting in Seoul. And then he asked Maren and the team and our community health worker to present at Meta Echo. So sometimes we have to switch gears when we're doing this kind of work. Sometimes we have to abandon idea. Sometimes we go in a new direction. Next slide, please. So why bother? Like, why co-produce? Well, for us, the simple answer is it works. You know, from randomized controlled trials to mixed method studies, co-production has been shown to improve patient outcomes, improve provider satisfaction, which I don't think ever gets enough attention, but build trust and relationships. And if there's anyone clinical or any parents out there, they all know that there's no behavior change without a trusted relationship. I mean, I've been in healthcare for 30 years, and providers know that the joy lies in those times when you make it with someone and you and that patient have an understanding. You become a two-person team and you do something that makes a difference in that person's health or life. That's like the juice. And for us, co-production does that at the community level. It provides real world relevance, like when is it best to have a vaccine clinic? Where should we have it? What information is helpful? It provides more diverse perspectives and knowledge, like why free care might not work in this community. It adds a layer of cultural competency. For example, there was a gentleman who wanted to know how I had the audacity to recommend a Pfizer vaccine to him because he was from Nigeria. It increases engagement, enhanced effectiveness. It promotes equity. So we have a lot more examples of the ways that when you have these pipelines of bidirectional communication, you get relevant information that can be used real time. Next slide, please. So I think if we back up a little bit, one of the things that we had to learn was this idea of we and them and us and them. So if you stop and look at your team, like who you're trying to research, what you're trying to research, who will be affected by that research, and then ask yourself who's missing. What wealth of experience or knowledge is not informing your project? That's sort of like the first beginning step. We learned that, like, for example, we learned that community health workers have all of this clinically relevant information, why patients don't fill their prescriptions, why they won't take their insulin, why they can't get vaccinated, what it means to them to actually try to get to an appointment. But that information was completely lost to providers. There were no communication pipelines. So clinically relevant information was just dying in a vacuum. We used co-production to try to help us figure out how to do something about that. One of the ways was to make sure that our community health workers had access to the EHR so they could let providers know. We had to have an equal platform of dialogue in order to address that particular issue. Next slide, please.
So Renee mentioned a bit about how co-production can be extremely effective when working in the community and with community health workers. We learned over the last 10 years from working with community-based organizations in our area how much knowledge and expertise CHWs have. So CHWs, I'll say, community health workers, and how their trusted relationships are crucial when working with our patients. But much of that work and information gathered is lost to the clinical world. So we built a co-produced CHW program, and since it is built by the community, we call it the Community Informed Care Initiative. even though it's a little bit of a mouthful, we can call it CC. We learned from the community what was needed through focus groups, our Project Echo series, our stakeholder group, collected stories that we gathered, and from that were distilled the bones of this CHW program. The reason this program continues to be successful is because from a co-produced process, the community was involved in the vision, implementation, and revision stage. Trusted relationships are key to health improvement, and we adopt this philosophy in all our initiatives so we can successfully sustain a program that lives in a space between the community and the hospital. So you'll see here our guiding principles, which we lead with for all our community-based initiatives. Our programs are co-produced, our work is done in the community, and the work that we do is evidence-based, meaningful, generative, and sustainable. Next slide, please. By creating this bridge of trusted care between the community and healthcare systems, we impact social determinants of health, respond to health needs identified by the community, and provide equitable access to healthcare for disenfranchised populations in Maine. This collaboration and community addresses inequities that contribute to poor health by creating connections and credibility. And coming from a big healthcare system, this took some time and finesse. We developed stronger relationships with the community to assure them that we are working with honest and transparent communication. We are here to learn from them. We are not here to take over the work, but we are here to help fill the gaps, immerse ourselves in the community, and really try to solve problems together. Together, we work in intersection between communities and health systems to promote care. Next slide, please. And when we think about healthcare, we know that the quadruple aim comes to mind to most providers. And even though we didn't intend to make this a quality improvement project, you can see here how we use co-production to effectively address social determinants of health and basic clinical care. And most importantly, the work that we do aligns with the goals of patients, providers, and the system. Next slide.
So to get to the money, which I think is probably what you guys are more interested in, is how could we think about co-producing research, particularly with immigrant communities or in the sort of landscape of meaningful community engagement. There's a growing body of research related to the effectiveness of co-production on community engagement, but there's less data sort of at the micro level, either with immigrant communities or local populations. For example, what sampling techniques should be used when you are crossing language and culture barriers? It's really hard. How do you process indirectly obtained information? One of the big things that's getting a lot of attention is looking at identifying appropriate validated measures of trust, and which ones are good to use in smaller groups. There are, we feel like this is like research gold, but we are not necessarily equipped to get at it. It's what we need is the research piece. We need expertise as well as data collection, analysis, infrastructure. I am not an expert in participatory data analysis, but it seems pretty clear to me that this would be a really good arena for participatory data analysis. Each component, formulating the research question, like having an advisory board that can really identify what research questions are most likely to bear fruit, looking at the study design, what sampling strategies might work, verifying if this is, if the sampling is appropriate, having researchers on our team, what methods might work in this community, what themes might come out of this research are all areas where co-production could probably add some real dimension. And to me, again, this is not my area of expertise, but to me, co-production seems very similar to participatory-based research, which I think is something you guys probably know better than I do. But the difference may be in the emphasis that co-production places on all steps, including as equal a partnership as possible. For example, maybe the composition of the advisory groups or the focus groups of research, or the focus of the research may be different between the two. Next slide, please. And lastly, I just wanted to have a shout out to Tom Boleke. I don't know if you guys are familiar with Tom Boleke. He's a Chief Global Health Officer at the Council on Foreign Relations, and he's done some really, really interesting research on trust. He has a lot of data that's, it's interesting to see how he presents his data and what data he uses for this work. but about how trust made the difference between life and death in the pandemic. And he does this from a country to country analysis. And he has a lot of interesting data on trust and its impact on health. And I think if it's an area of interest, I would encourage you to look him up. He's got some really cool data. And with that, I think we'll stop the didactic part. Thank you so much.
Thank you for this really thought-provoking presentation. I'm wondering if there are folks who have questions or comments. Yvette.
I could not find my hand thingy, but I wanted to ask the speakers about the recruitment of the community health workers, and what do you tell them about the time commitment, and how much of it is work for them, and how do you compensate them for that time and that work that they put in? Like, to build that trust, you have to be honest about their, the commitment that it'll require. So what's that conversation like?
So, it's a really interesting question because there's actually a lot under that. Like, for example, Marin has been working with these community organizations for 10 years. And so a history of honest, transparent communication. You don't say anything, you don't make any promises you can't keep. You represent things honestly. Like, one of the things that we come up with against a lot is why, they see me or Marin or someone, I'm white, middle-aged, and part of the system. And that may not be how I view myself. And there are some facts in there that I might like to deny, but that's how I'm seen. And so they think that I have the power to make all new appointments for all immigrants at least an hour and a half long. So I think there's a lot of management of expectations. And so what we do is we just tell them honestly what we're asking, what we know, what we don't know. Another thing that there's a lot of structural racism, there's a lot of mistrust, and there's a lot of history of how CBOs have been treated. The doctors that contribute to our initiatives, aside from the fellows, are kind of doing a lot of it on a volunteer basis. None of the CHWs that work for CBOs and not our own, but will do anything on a volunteer basis. Well, that's not true. They do a lot of volunteer stuff as part of our advisory councils. But if they're participating, we have just, a very small flat rate for compensation because and that is not so much honestly about the money, but about showing that we respect their time. And that's really important. So that is their industry standard. It is not what happens on the hospital side, but it is what happens on the community side. So we have to figure out what is the expectation and then talk about whether we can meet it or not. But I think open and honest dialogue is probably the most important thing. Does that answer your question?
Yeah, thank you.
Marin, did I leave anything out?
No, I was just going to add, I think where we saw the biggest need and the most impact that CHWs were having in our state alone was really eye-opening. I mean, in the past, we've always contracted out with community-based organizations to help CHWs reach the non-English speaking populations in Maine or vulnerable populations in Maine to help improve colorectal cancer screening or breast cancer screening or whatever it might be. And then what we saw in the pandemic was these CHWs within the community-based organizations, how much they were doing. They were going to people, they were frontline workers, going to people's houses, taking them to the ED or urgent care, being responsive day and night, text messages, WhatsApp, calling day and night with questions, because most of the information that these communities were receiving was either information from family back in the Sudan or through Facebook or through other not so credible media sources. So with that stemmed the Ask the Doc series, where we brought a fellow in to co-produce and co-facilitate a Zoom session with the Maine Access Immigrant Network with their CHWs. And what we found was, and from the presentations that I've even been included with community-based organization, is how much is missed when a community health worker works with a patient, and that how much communication is missed to the provider. And that these community health workers are not paid very well. They're not recognized very well, yet they're working 60, 80 hours a week. So we wanted to reinforce the necessary importance of this workforce, and by bringing CHWs into the main health system. And we actually created the first job description to go live up in the main health system. And we're grant funded program right now, and hopefully not forever. And we brought in the first CHW to help kind of create this program. So she worked with myself and Renee and our preventive medicine fellows and Tina Holt to really develop the EHR workflow. What kind of access do they need? Train them in the EHR and in documentation and what that looks like of adding yourself to the care team, documenting the patient progress. So the provider on the other side can see what's happening that they're not seeing in an exam room. And that direct bi-directional communication is so effective because nothing really is getting lost. So every visit isn't really like starting from square one because we can see the progress in the patient's history. So it is very, we shift the dynamic power really shifts with this because I learned from my CHW what is actually happening in the community, which is why it's so important that our program is in the community and not in the clinic, even though the CHWs can go to appointments in the clinic with them. But they teach me what's actually being said. What are the rumors around the vaccine? What are the fears? What are the hesitations in going to your prenatal visits? What are they worried about the developmental screening the doctor is providing for their child? And then that way we can kind of, again, that iterative process, just shift our program and shift where we are in the community, and then educate also the providers on what is actually like how to help them be more successful and efficient in an exam room by us taking on that social determinants of health and that stuff that happens outside the exam room.
And I just put a plug in because I think if we can find the link, last week's was a whole hour on this, the Grand Rounds presentation, and you could really Dr. Press presented part of that, and he really talked a little bit about how the community health worker program works and how those relationships are formed. But he also spoke a little bit about research and that there's some constraints because you have a time frame and you might have an objective that you can't necessarily change, but co-production can still work. And I think at the heart of what we do as community engagement navigators and, trying to connect researchers in the same way so that you have all the information you might not have as you're designing a study. You know that it's co-production, but one of the byproducts or sort of at the heart of it is knowing what is going to work, knowing what the community, and in my experience, there's no shortage. I follow Peggy Warner's work, who was one of the first people through PCORI who started some of this, and she has a community group. The other thing is meeting over time. We have to find a way not to make it grant specific, but to keep those relationships going even when the grant ends. Her community group came up with 17 research ideas. So like there's no shortage of research ideas, I think, at the community end of things as well. And Becky, I'm going to come to you next, and then if anyone else has questions, please raise your hand so we can answer them before we move to the case. Go ahead, Becky.
Thank you so much for that. That was wonderful. My question is in regards to maintaining what you mentioned, Carrie, maintaining contact with the community after the grant is over. I know that's like a huge problem, and I've been working on a project where we have stakeholders, and that's something that's come up. We work together. I think you're like my friend and colleague that I'm treated as an equal, but then the grant ends and then that's it, and I'm just dropped like that. And so, so what have been some strategies that, you've used just to be able to address that and maintain those relationships?
Well, I think, one of our guiding principles is that our program be sustainable. So even past the grant, that we will be able to sustain this program and this workforce. And luckily, we are seeing community health workers like blossom in the whole country and the world, really. And it's nice to see that happening in Maine too. A lot of our local health systems are hiring on CHWs now, some grants, some not. But we're all working together to create workflows, data collection, outcomes, processes, kind of standardization across the board. So we could kind of have this proof of concept show the return of investment of reduced unnecessary service utilization, reduce ED visits, improve provider satisfaction, reduce their burnout, improve patient satisfaction through experience surveys that we love to send out. And so we are working up to that exact goal of making this, you know, an operational piece of our system of having this direct community health worker outreach and education. Renee, did you have anything to add? I think you were going to talk.
The only other thing I was going to say, and in terms of actually doing the research, I mean, we have the network. What we don't have is the research expertise. So that's why maybe some of these collaborations, because you know, we have been working on creating these relationships for about 10 years, or Maren has. And so if you have a network that has the pipeline, then maybe the answer is figuring out how to collaborate with the pipeline. And I think that's why sort of this is exciting to us, is because we're going to be here, we're going to continue to be here, and we're going to continue to work with, you know, to live in this weird space that is between people's homes and their hospitals. But I think that there are a lot of opportunities to collaborate with people who are more focused on just the research. And it's almost analogous to the fellows. Like we have it, you know, it's going to morph and evolve. And I mean, we use this analogy all the time that like, you never stand in the same river twice, but what are the guardrails? So some of the guardrails are these relationships and these networks, but the fellows are going to come and go, and they're going to be facilitators. They're going to be doing research. They're going to be involved. They're going to be the clinical supervisors, but it's not always going to be the same fellow. So if we had like a research person on one of our advisory boards, it doesn't matter if it's always the same person over time. It's the concept of having somebody who can sort of give that perspective and that expertise and that viewpoint to what we're doing. Great.
Yeah.
Thanks.
Yeah. Well, I'm going to turn it over to